Hi everybody, now we are going to continue our topic with a mini topic of aortic root replacement. Homograft aortic root replacement. Homograft aortic root replacement introduced by Ross has been performed to treat lesions of the ascending aorta, such as aneurysms and dissections, to treat complicated bacterial endocarditis with aortic root abscesses, and in the management of complex left ventricular outflow tract obstructions. In the latter group, the removal of the native stenotic and fibrotic aortic root opens up the left ventricular outflow tract and can often relieve subaortic gradients with or without an additional septal myotomy or myectomy. Aortic root replacement has two main advantages over the freehand homograft replacement. First, the valve is more likely to remain competent as it is inserted as a functional unit. Second, a valve of greater diameter than the native valve can be inserted if implanted as a root. The operation is performed using hypothermic cardiopulmonary bypass with a single atrial cannula for venous drainage and a high aortic cannulation. The left heart is vented. The pulmonary artery is separated from the aorta. The cold blood cardioplegic solution is infused every 20 to 30 minutes. The first infusion is into the aortic root if the aortic valve is competent. A proximal transverse aortotomy is first carried out to examine the aortic valve, the left ventricular outflow tract, and the coronary anatomy. If the decision is made to proceed with the aortic root replacement, the proximal transverse aortotomy is completed. At this stage, protection of the coronary arteries is of utmost importance. First, the back of the aorta is cut away from the left coronary orifice, leaving a disc of at least 3 or 4 mm of aortic valve as a cuff. The right coronary artery is also removed with a shield of aortic valve, and the rest of the aorta is now cut away freely, leaving some remnant of fibrous tissue anteriorly on the septum for later attachment of sutures. Any subaortic obstruction is now fully accessible and should be dealt with by inoculation or excision of fibrous tissue or muscle. Root enlargement is performed if necessary. The proximal coronary arteries are then fully mobilized using sharp dissection. Care must be taken not to perforate the main pulmonary artery during this dissection. This is easily done during a reoperation. A full mobilization of the coronary arteries is important as they have to be reimplanted slightly higher than their original position in the native root. The ossers tend to leave the superior edge of the coronary cuffs straight, like a shield, for orientation at the time of reimplantation. State sutures are then placed on the aortic cuff surrounding the coronary arteries so as to retract them outside the operative field. Now we will go to see the figure 37.13a. Here we see the right and left coronary arteries that were dissected, and we see the pulmonary artery homograft that are beginning to sew, and next will be the B. An aortic homograft of appropriate size is chosen. In children, it is always possible to use a larger homograft than the native aortic root. The larger size of the new aorta emphasizes the importance of fully mobilizing the coronary arteries to avoid subsequent tension when they are reattached to the new aortic root. The lower margin of the homograft is sewn into the left ventricular outflow tract. We prefer, as Ross suggested, to have the valve oriented into the anatomical position so that the left coronary sinus of the homograft corresponds with the native left coronary artery. The circumference of the outflow tract is first divided into 3 by a set of chemistry marking sutures, and subannular interrupted sutures are placed in each sinus in a sequential manner. With all the sutures in place, a strip of autologous pericardium can be positioned around the aortic root, and interrupted sutures are snapped down onto it. Figure 37.13b. The left corner stump on the hemograph is widely excised, and the bottom of the native aortic valve surrounding the left coronary artery is anastomosed to the homograph with a running 6-0 Prolene suture. The figure is 37.14. An alternative technique consists of rotating the homograph 120 degrees so that the right coronary artery ostium faces the recipient's left coronary artery. This has the advantage of avoiding sewing muscle to muscle and probably resulting in a more secure suture line, which can be done with interrupted sutures or with a running suture of 4-0 Prolene. The left coronary artery is then sewn into the enlarged ostium of the homograph's right coronary artery. The left coronary artery of the homograph is closed with a 5-0 Prolene suture. As a result of the rotation of the homograph, the aorta has a tendency to curve to the right. This can be rectified by appropriate beveling of the graft. Ross suggested reimplantation the right coronary artery after completion of the upper anastomosis of the aorta, which is then placed under tension by temporary release of the aortic clamp to facilitate the sighting of the right coronary artery, the origin of which is highly variable. The figure is 37.15. In this figure, he emphasized that the right coronary artery anastomosis can be done after the completion of the proximal anastomosis, and this is the figure of 37.15. Care must be exercised not to damage the aortic cusp during this maneuver. A marking suture placed before the aorta is closed may be useful. Pulmonary aortograft root replacement. The idea of transferring the freehand pulmonary valve to the aortic position combined with right ventricular outflow tract reconstruction was introduced by Ross in 1967. The pulmonary aortograft route has one more major advantage, as the neo-aortic valve is more likely to remain competent as it is inserted as a functional unit. However, the prerequisite for the success of this operation requires the utmost attention to the construction of the many suture lines. Contraindication for the Ross procedure considered in our institution are doubly committed subarterial VSD, dysplastic pulmonary valve, and significant coronary artery crossing the proximal right ventricular outflow tract. Any major discrepancy between the sizes of the two outlet valves is also a relative contraindication. The operation is performed using hypothermic cardiopulmonary bypass with bicaval cannulation. Before the cannulation, the ascending aorta and the pulmonary artery and its branches are extensively mobilized. The left heart is vented via the right pulmonary vein and later on through the transected pulmonary artery. If the decision to replace the aortic valve with a pulmonary aortograft has been made, and if the aortic valve is competent, the pulmonary valve can be harvested before the aorta is clamped. Otherwise, the aortic clamp is applied and the transverse aortotomy is made. The cold blood cardioplegia solution is administered every 20 to 30 minutes. The first infusion can be made directly in the aortic root if the aortic valve is competent. The preparation and dissection of the left ventricular outflow tract and the dissection of the coronary arteries are the same as for the homographed root replacement. Harvesting of the autograft. The main pulmonary artery is transected just proximal to the bifurcation. The pulmonary valve is inspected to make sure that it is normal. The base of the pulmonary valve is then separated from the root of the aorta by sharp dissection. The figure is 37.16. Here the sharp resection between the pulmonary artery and aorta.